Hello guys, sorry for the delay. Hope you can see me and you can hear me as well, right? I hate this YouTube ad in front of it. Okay, so let's start. So today we're going to discuss about renal, and just to make sure our routine, we have a 7 p.m. YouTube session daily. Good evening, Dilip. Hello Arun, we have started it now. And we have an Unacademy app discussion. Same today. Today's topic will be on non-neoplastic renal conditions. Especially our topic is going to be on glomerulonephritis, right? And we have a 1 month subscription. If you guys want anything, help for the recent upcoming exam, you can use any code if you have. If you don't have a code, you can use Pathocups. Good evening, Shastri. Good evening, Deepa. Okay, so let's start with it. See, glomerulonephritis is an important topic, and images of glomerulonephritis do come. There are few areas which I feel that it's a bit difficult for you guys, which can be easily sorted out by comparison. The problem is we see KW lesion separately, we see IgA nephropathy separately, so I'm not able to differentiate both of them. So we'll see both of them. We are going to compare everything today, and maybe with different permutation combination, we are going to diagnose them. Fine. So for that, I need to know the H&E images first and the immunofluorescence images next. Fine. It's like same like patterns of neoplasia. Everything has patterns in pathology. Glomerulonephritis also has patterns in pathology. The first pattern in H&E is my diffuse proliferative pattern. Okay, is your diffuse proliferative pattern. So when I say diffuse proliferative pattern, I am not just talking about there is endocapillary proliferation. I'm going to have more amount of your neutrophils, everything in the glomerulus. Fine. Good evening, cardiac surgeon. Good evening, Avent. And I'm going to have more of neutrophils, WBCs inside glomeruli. Okay, this is my diffuse proliferative pattern. I will see diffuse proliferative pattern in PSGN, the first finding. That's going to be the first common finding where I can have a history also, or your post-infectious glomerulonephritis, anything. We can have them in MPGN, membranoproliferative glomerulonephritis can also have it, and obviously SLE will have it, though our clue for diagnosis of SLE is not based on this pattern, right? The second pattern is, it's in membranous pattern, my membrane thickening. Here I won't have many WBC, I'm just going to have membrane thickening only, just membrane thickening. The glomerular basal membrane becomes thickened. Two possibilities, membranous glomerulonephritis. The second is my Goodpasture syndrome. If it's along with lung, if it's not with lung, I call them an anti-GBM glomerulonephritis. Fine. The third pattern for me is mesangial. Okay. Go look at mesangial. Fine. Yeah, your dense deposit also will come here. It will also have predominantly mesangial thickening, not my membrane thickening. Fine. When I have mesangial expansion, my first possibility is mesangial pattern means mesangium is going to become bigger. That's all. IgA nephropathy. If it's along with vasculitis, Hinault's colon purpura, your dense deposit disease C3 glomerulonephritis predominantly has mesangial pattern. See, generally this disease, MPGN C3 dense deposit disease, is not for undergraduate. I would at least prefer not to give an microscopic image for MPGN and C3 dense deposit disease for undergraduates, because it's a bit difficult, it's a bit complicated, it's a very complex disease, right? These are the H&E pattern for me. And in immunofluorescence, it's very simple because I have only two appearances. One in the capillary, one in my mesangium. In capillary, again I have two possibility. When I have in capillary, it's linear or granular. Okay, that's all. Or I'm going to have the positivity in the mesangium. You know what is happening in linear? Linear is going to be Goodpasture syndrome. Granular, you know, rest almost everything will be granular. Your MGN, your MPGN, your PSGN, everything is going to be granular positivity only. I'm just going to have granular positivity. In your question, it will be written what immunoglobulin it is. IgG or IgA, whatever is required will be there in your question, absolutely, because every immunoglobulin in microscopy will look green in color only, right? And yeah, mesangial pattern as well. Mesangial pattern, if it's positive in the mesangium, my first diagnosis again is IgA nephropathy. There is something called as mesangial rings. If it's in the form of a ring is just a round one, right? The form of ring, I'm going to think of an MPGN. Especially my C3 dense deposit disease group. Fine. Okay, these are the patterns I'm going to have in my immunofluorescence. Electron microscopy, we hardly use it and we'll see them as well. Okay, so with these patterns, I'm going to have a permutation combination. Let's say that membrane thickening plus linear, Goodpasture syndrome. Membrane thickening plus granular, membranous glomerulonephritis. Diffuse proliferative plus granular, I'm going to have PSGN. Diffuse proliferative plus mesangial and granular, I'm going to have MPGN. Diffuse proliferative, SLE is, you know, right? SLE will have Fuller's effect everywhere. Everywhere, everything positive, SLE, right? Mesangial expansion and my IgA deposit in mesangium, IgA nephropathy. Mesangial expansion plus ring forms, C3 glomerulonephritis, right? We are just going to have permutation combination of these and then we are going to diagnose it. Our main goal is here is to diagnose. I'm going to show you images. There will be one image on histopathology. You have to pick them up. One image on immunofluorescence. You have to pick them up and you're going to write the answer. No history, nothing. You can easily pick up with this these two combinations. These two combinations are enough for us to diagnose it. Fine. Okay. Let's go to the first one. Both are abnormal here. I have an H&E. You're going to say what pattern is there in H&E and what pattern is there in immunofluorescence, and then you will decide my diagnosis. Okay. You can comment whatever comes to your mind, but I want you to comment. Perfect. Membrane thickening, granular. Diagnosis. I didn't even tell you what immunoglobulin it is. Membrane thickening, granular. That's enough for me. See, this membrane thickening, this is not diffuse proliferative. I'll show you diffuse proliferative. My diagnosis, MGN. Right? That's all. I don't want history. I don't want my clinical features. I don't want anything. Membrane thickening, granular. Your question will say it is IgG. Then yes, my diagnosis becomes much more confident. It has to be in membranous glomerulonephritis. That's all. Okay. Again, two patterns. I have an immunofluorescence, I have an H&E. Diagnosis. You're just going to say what pattern it is and we are going to come to the diagnosis. H&E is almost the same. IF alone is the different. Membrane thickening plus linear, right? Goodpasture syndrome. That's all. See, actually I use the same image. For these both, I use the same image. If my immunofluorescence changes, my answer changes, right? I'm having a membrane thickening plus my linear pattern. It has to be a Goodpasture syndrome. You will have a history. You will have, if it's syndrome, you will have your lung involvement as well. Otherwise, I'm going to call it an anti-GBM glomerulonephritis. That's all. Fine. Membrane thickening, linear pattern. Got it? Okay. Okay. Tell me the pattern. H&E and my immunofluorescence. What pattern you see here? Same thing. We're just going to compare and we're going to come to answer. A clue maybe to highlight what are these guys. There are lots of these guys there. Too many of them. These are diffuse plus granular, right? Hypercellular, diffuse plus granular. Diagnosis. And I'll give you a history that this is IgG and C3, the granular image. If with an infectious etiology, I'll go for PSG and PIGN, right? I have neutrophils here, diffuse plus granularity, C3 and IgG. This will be there in question. Don't worry about it. My answer is going to be PIGN or PSGN based on the history, whatever infection I have, right? That's all. Okay. Next, I have two immunofluorescence image here. Tell me what is the first image. First image just now we saw. Where we saw? We saw them in Goodpasture, right? So this is my linear positivity. Okay, this is my linear positivity. Fine. So if I look in the other one, actually this is where my capillary glomerulus is, right? This is where my capillary glomerulus is. All these are capillary glomerulus here, here, here. So what is the positivity in the second image? If you superimpose, it will exactly be mirror images, right? The first image is linear, the second image is mesangial. Your mesangial positivity looks like this. Okay. If you're just going to superimpose, they both will fit perfectly. One is linear and whatever gap is there is either lumen or mesangium. Here, whatever is positive is mesangium. This mesangium positivity, if it is IgA, my diagnosis is straightforward. IgA nephropathy. If I'm going to say this mesangial deposit is C3, what would be your first thought? And no IgA, only C3, I'm going to think of an MPGN, C3 glomerulonephritis or dense deposit disease, right? So your answer is based on this, and this information undoubtedly will be there in your question. Okay, just going to compare. You have to know how an immunofluorescence of mesangium looks like. This is how it's going to look. Fine. Okay, perfect. Okay, I'll tell what's the first. There are two images here, two H&E images. Identify the difference. Tell me what is 1, what is 2. What do you see in 1, what do you see in 2? Okay, 1 is normal. Perfect. What do you see in 2? Which compartment is more in 2? Is it diffuse pattern? No, it's not diffuse pattern. It is not my membrane thickening also, right? It's not membrane also. The second one is mesangial. Perfect. See, this is how my normal mesangium is, right? Only this much is normal mesangium. I am definitely right in saying that this mesangium is bit more than normal. It's bit more. It's mesangial thickening, right? This is my mesangial pattern. Fine. So when I have mesangial pattern, again the comparison will be like this. This mesangial pattern with this immunofluorescence. I'm going to say IgA nephropathy, same mesangial pattern plus immunofluorescence for C3. I'm going to say MPGN. That's all. Fine. This mesangial expansion. Fine. One common confusion is between the mesangial expansion and your KW lesion. You guys get easily confused between mesangial expansion and KW lesion. We'll compare them both. By comparing that, it will eliminate all your doubts. That's all. Fine. Look at this. Again, I have 1 and 2. The second one is the same image what we just saw, the mesangial deposit, right? Tell me what is glaring difference between mesangial deposit and KW lesion. I want you to tell. You comment on the difference. You will definitely identify you will never confuse it any time further. KW looks nodular. Perfect. That's one finding I want you to remember. KW is nodular glomerulosclerosis. It will be nodular. This is not nodular, right? This is definitely not nodular. This is definitely not nodular. It's irregular. Mesangial expansion will be irregular for sure. Cyanthine, it's pink in color, more pink in color because the first one is PAA staining, right? That's the reason it's more dense pink in color. Fine. One, and the most important thing is it has to be nodular. When I say KW, it's nodular glomerulosclerosis. That's the first thing. If I have a tiny nodules, where did it go? Sorry. See, if I have tiny nodules, I'll have a trouble here. It will not. This is a very, very big nodule, so it looks superb. When it's a tiny nodule, it becomes a bit difficult for me. When I'm going to have a tiny nodule, how I'm going to differentiate that is, look at this. If I'm saying this is a nodule, look at the periphery. Every nodule, look at the periphery. Every nodule, look at the periphery. Can you see the capillary loops? Because it will expand. See, nodules expand. Mesangium creeps inside. Mesangium is infiltrative. I have 3-4 capillaries like this. Mesangium can infiltrate the capillary loops. Nodule is, it's going to expand and push the capillary loops. Always nodules will have capillaries prominent on the outer surface. That's the second clue. The second clue is, one is nodular. If it's big nodule, you see, if there's smaller nodules, there will be capillaries on the outer surface. Okay. On the outer surface, there will be a well-formed capillaries. So that's how you're going to differentiate KW lesion if it's given in an image. Because these are two things which might cause a doubt. From now on, you should not have a doubt. We just put whatever is causing a doubt near to each other. You will definitely know the difference. Nodule versus mesangial expansion. Fine. And obviously, you'll have an history of diabetes. And there you'll have a recurrent hematuria in case of an IgA nephropathy or whatever it is. Fine. So these are few H&E images and your electron immunofluorescence images I want to compare. Electron microscopy. One electron microscopy all of us know is effaced food process. That's the easiest one. You don't have food process, that's an effaced food process, right? So we'll just compare a few more. Again, I have 1, I have 2. Which is normal? Which is normal? We're just going to compare. Nothing else we're going to do. Because you guys know already everything. I'm just going to add a little bit more clarity to it. That's all. 2 is normal, undoubtedly, right? And it's written also my GBM, right? So here also it's written here, my GBM. Okay. So here it's written that it's platelets. So can I call this a cell? Somewhat similar to my platelets because it has an endoplasmic reticulum and everything, right? So can I call this a vessel lumen? That's my vessel lumen, right? So I know the vessel lumen means this is endothelium, this is epithelium. It's also written epithelium. I don't expect these markings always, but here it is written. I have to understand which is subendothelium, which is subepithelium. That's all. If I know it's basement membrane, you can see the dark areas here, right? This is definitely darker. We call all the deposits electron dense deposits, right? Electron dense deposits. So which means every disease, the deposit will be black in color than my normal color. This is normal. Than this, it will be blacker, right? So tell me, where is the location? On the epithelial aspect or on the endothelial aspect? It's on the epithelial aspect, right? The deposit is, I'm just going to erase this. Deposit definitely on the epithelial aspect. So this subepithelial deposit or subendothelial deposit. This is my subepithelial deposit. Okay. In subepithelial deposit, I have two guys. Again, electron microscopy is also pattern only. I have only three people. One is dense deposit disease exactly on the basement membrane. Other guy is subepithelial. Other guy is subendothelial. Fine. I have only two people in subepithelial. Common differentiating finding. One is PSGN, which will be subepithelial. Membranous glomerulonephritis will be subepithelial. Okay. So look at this guy. Here, I will circle all the deposits. I'm having a deposit here, 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 here. See, I'm having deposit all over. When I'm having deposit all over here, am I right in saying that this looks like some autoimmune pathology where against a normal component of the basement membrane, I'm having antibodies against it, right? It's all over, right? It's all over. If it's all over, my first possibility is it's an intrinsic problem. It's not coming from outside. I'm having, let's assume I'm having an, whatever it is, some thing I'm going to throw to a place. I'm going to plant it someplace. It'll get deposited only in one place. It will not be uniformly distributed like this, right? So if it's uniformly distributed like this, it has to be in membranous glomerulonephritis. This is how MGN looks. It's not planted, it's intrinsic. Your PSGN or any PAGN is a planted antigen. I'm having this much place. I'm just going to drop something like this. It lies only here. It will not go here, 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 like that, right? It just go into one place. So how a PSGN will look is, again we are going to do the same thing. We're going to compare. Okay. Again, we have two images, 1 and 2. One is the same image normal. Basement membrane, yes. So what are these layers? Epithelium, yes. Undoubtedly it's simple. So again, I have the multiple granules inside, platelets I have. I know endothelium, I know epithelium. Look here, I have only one deposit here. A big huge deposit, right? So here it's not uniform, right? Here it's not uniform. I have a single huge deposit. So do you think I have planted something or there's a problem between the intrinsic basement membrane? It's something planted, right? This may, like someone, like the lip side, it's in subepithelial hump formation. It's normal, flat, suddenly a huge thing, subepithelial hump formation. So this I'm going to call it an most likely a PSGN. Obviously I need history of streptococcus or PAGN if there's any other infection, right? Now we'll just compare these two guys. I'll erase everything whatever I've drawn, right? So that we can see it in comparison. Leave the normal ones, compare these two because both are subepithelial deposit. Can you find a difference? One is just a single one, other one is continuous. That's what I want you to understand. MPGN will be continuous because an intrinsic problem, autoimmune problem. PSGN is planted, so only one place, everything is aggregated, it's going to be huge. Fine. That's the difference you want to know. Normal we already know. Fine. This is one thing I want you to understand in electron microscopy. Next. Again, we have two images, 1 and 2. Okay, let's see. Again, same comparison. One is still normal. Second, we'll look at it. So tell me, this one. This is some dark colors there. Some cell is there. So what is this side? Subendothelium or subepithelium? This is my vessel wall, right? This is my vessel wall, vessel lumen. So I'm having a basement membrane here. I'm having someone coming and sitting here, right? So I'm going to call this an subendothelial deposit. Again, compare it with normal. I have some cell here, so that's a vessel lumen. I have a dark deposit below my basement membrane, so this is how a subendothelial deposit looks. Okay, in which condition do you see subendothelial deposits? In which condition do you see subendothelial deposits? One predominant person is SLE. Absolutely in SLE, I will see subendothelial deposits. We will see why also. The second one, what I want you to remember is C3 glomerulonephritis. In both these conditions, PSGN I would keep them. PSGN will have everything, right? Mesangium, subendothelial, subepithelial. So I'm keeping them a little bit later. Fine. My SLE, C3 glomerulonephritis. We used to say MPGN because the most common cause of MPGN was lupus nephritis. That's the major cause of MPGN. So MPGN and my C3 glomerulonephritis, right? So let's take SLE. What's the problem in SLE? Circulating immune complex. C3 glomerulonephritis. Who's the problem? Complement. Where do you see the complement? Plasma proteins. So So am I right in saying that every damage in both these conditions comes via the vessel? Yes, it does not come from outside, right? It comes via the vessel. So all the damage comes from the inside. So both of these guys should be having definitely subendothelial damage only. They'll come and damage inside. So they're going to come and damage in this place. Everything is going to destroy this place, and this makes it leaky and will have the symptomatic, right? So these two, if you remember, for subendothelial deposits, more than enough. Like Shashi said, PSG also is a possibility, maybe down the road, right? So electron microscopy is not alone diagnostic. I need other people also to help me to diagnose, okay? So we know subendothelial, we know subepithelial, fine. Okay, tell me this finding. 1, 2. Just whatever comes to your mind, tell what you're seeing here. One is the same image, normal image. I have not changed the normal image. Tell me what is strikingly different in 2. I don't want the correct answer here. I don't care if you don't give the correct answer. I just want you to think, see the image, whatever comes to mind, say that first. Yeah, leave the normal. One is normal. Whatever comes to mind. Great. A thick membrane. Superb. Superb. See, there's a measurement also given here. 0.73 micrometer. The normal thickness is, you need not know this, it's 0.35 to 0.4 micron. Okay, that's how the normal thickness here. You are correct in saying that the basement membrane is thick. I just want you to add one more thing here. Is the basement membrane thick, made of normal component, or is it densely thick, which means is it black in color? Is it black in color or similar gray texture only? It is similar gray texture, right? It's not black in color. I'm not having a deposit like what I saw previously. It was deposits. It's not dense. It's not dense. I'll show you dense. Because we have not seen this condition in electron microscopy. So we are answering it's dense. It's normal only, right? It's normal. It's a bit zoomed up, that's all. I'll show you the black color. Am I right in saying that this is the black one? Obviously. We'll compare it. See, everything goes with comparison. Compare these two. The below one is definitely blacker. Yes. So you just have to compare. The below one is 100% darker than the above one, right? So the below one is whatever you know already. This is your dense deposit disease. I'm not going to talk about that because you guys already know that, right? So we'll leave that. Your MPG and type 2, C3 glomerulonephritis, everything will be there. Now I'll come to this. You guys only said that this is thicker, but when you compare to the below one, it's not dark. It's same thicker, same gray color. What comes to your mind? Diagnosis. We have read this. You know this finding. I just want you to link it. That's all. A thick basement membrane without immune complex. No. A thick basement membrane without immune complex. You guys know 100% this answer. Okay, I'll rephrase the question, you will know the answer. What is the earliest change which happens in diabetic nephropathy? Basement membrane thickening, right? This is diabetes. Okay, just your diabetes. The earliest change in your diabetes is thickened basement membrane. This is how a normal thickened basement membrane looks, right? This is the thickened basement membrane. The earliest change in diabetic nephropathy is a thick basement membrane. This is what I'll look. This is a normal basement membrane, thick in color. No immune complex, nothing. It's a thick basement membrane. That's all. Fine. Okay. If at all I want to ask you, see, no one is going to do a biopsy first. No one is going to do an electron microscopy. But you can't imagine your examiner what they're going to ask. It's a normal basement membrane thickening without immune complex. That's the important thing. When there's no immune complex, we already know that diabetes will be negative on immunofluorescence because no immune complex. Diabetes is true thickening of basement membrane because it's made of same basement membrane material, right? So this is a true thickening of basement membrane seen in diabetes, fine. And the false thickening or whatever you want to know is this one. This is your dense deposit disease, which we already discussed, right? Again, one is normal, this one your dense deposit disease, right? So we know what happens in my intramembrane as well. We know subepithelial, we know subendothelial. These are the only two changes which can happen inside the membrane. Just one to finally finish with. Okay. Tell me what's happening here. Again, 1 is normal, 2 is the abnormal thing. Okay, what cell is this, or what layer is this? This is your epithelial layer, right? You can see the food process nearby. That's simple, that's a straightforward one, right? You can see the food process nearby, right? Perfect. My basement membrane here is kind of becoming stretched like this, and it's getting destroyed. This is my subendothelium. That's also correct here. I'm having subendothelium, I'm having subepithelium. Like Sayantan said that my basement membrane is getting destroyed here, right? Is it completely cut off, or it is just been lost at some points? Is it still intact? It is still intact for me. Yes, little bit of basement membrane is stuck here slowly, but it's a bit destroyed. I'm not having a rupture. Rupture will look different. I'm not having a rupture here. Let's assume the basement membrane will be like, if I want to compare, I have to keep it in the size of a rubber band. Okay, I just took this. This is a very stupid way to explain, but I hope you'll be understanding it. Let's assume I'm having a basement membrane like this, thin like just a plastic cover. Okay, plastic covers a band, by the way. Fine, and I'm going to stretch it. Can I have tiny dots on this? Can I have dots on this? Because I'm stretching more and more, it will be dots. I'll have it. So this is how it looks. This is your which disease? Which disease? Your basket weave appearance, right? Then I'm going to stretch it completely. I'll have multiple dots like this. Disease? It's your Alport. It's just your Alport. So what happens in Alport? In Alport, I'll have less basement membrane material. I don't have enough collagen, so it becomes thin like my plastic cover, and this is still my basement membrane is there. It's not completely absent, it's thin, that's all. When it's thin, my blood goes and hits it again and again, and it becomes very holes. Like basket weave is nothing but holes, right? So it becomes like that. That's how it looks in Alport. Alport can be very thin basement membrane, or it can have an appearance like this, a basket weave appearance. Fine. Okay. That's a rupture of basement membrane. We have already seen. There's a NEET recall as well. You know how to identify that. It will be broken. There will be discontinuation of these two. That's a very simple one. I didn't include that. Fine. We just want to compare. Okay. So last image, I wanted to finish with this. See, we didn't go anything with pathogenesis. We had 2 or 3 patterns. Few for light microscopy, few for your electron microscopy, few for your imaging. Fine. Right. So what we are going to do is, it's just permutation combination. That's all. In addition to this, in an MCQ, you will have a 4-5 line long history and 4 options. Life should be easier, life should not be difficult. Don't overthink, just compare, match, miss and match, it will be correct. Fine. We'll see you by 10. See you by 10. You can download the Unacademy app for the classes, and you can have your subscribe to the channel if you want more YouTube things. Fine. Okay. So see you by 10. By 10 p.m. we'll have the session on renal glomerulonephritis part 1, MCQs on that. See you there. Till then, bye bye. Thank you guys. Varun, I'm not able to understand. They can expect us to diagnose thin basement membrane. See, I'm asking a question like Alport, I'll give you a history of keratoconus with a hearing defect with renal defects. That should be enough to diagnose its Alport, right? So I'm not going to give this alone. We are reading like this, fine? So I want you to be prepared for the worst. Even if you're given a single image also, you can pick up Alport. If you can pick up this and syndromic manufacturing, you'll be able to easily pick it up, fine? Yeah, 10 p.m. in the Unacademy app. Okay, Aruna? Thank you guys. Thank you for your time. Hope it is clear, Varun. If you are asking only the thin basement membrane disease, not Alport, that will not be asked alone. It will be like an Alport syndrome only. Fine. See you. Bye.